Important session on chronic non-cancer pain management. So we have, I'm privileged to introduce two eminent faculties today, one from India and the other from abroad. So first of all, I would like to introduce Dr. Raghavendra. I think Dr. Raghavendra doesn't need any introduction because he is very familiar to Indian palliative care, pain and palliative care professionals. So he is a lead consultant in pain palliative and rehabilitation medicine at Aster Hospitals, Bangalore. And he is director of Relief Pain Centers, as well as secretary of ISSP Karnataka chapter. And many of you know that he is also the editor of Indian Journal of Palliative Care. He did his MD in anesthesiology as well as DNB. And he has an academy fellowship for acute pain management and fellowship in pain management, both from Singapore as well as from USA. He is also a fellow of Indian Society of Pain Academy, and he also holds MSc in palliative medicine from Cardiff University, UK. And his special areas of interest are interventional pain management, neuropathic pain, cancer pain, chronic pains like spine pain, fibromyalgia, and end of life care. So welcome, Raghavendra, to this session. And our second faculty is from UK. Even though he's from UK, he's an Indian. So Dr. Ajit, who is a chronic pain medicine consultant since 2017, and he is working as a pain medicine consultant at the Imperial College Hospital Healthcare NHS Trust, London. And he is a member of International Board of the Spine Intervention Society, USA, and Interventional Pain Special Interest Group of British Pain Society. He did his MBBS from Government Medical College, Trichy, and MD from Madras Medical College. He did his fellowship training in interventional pain management at Brighton and Sussex University Hospital, NHS Trust, UK. And he was trained under renowned faculties, pain faculty like Dr. Stephen Ward, who was the chairman of NICE guidelines on low back pain and sciatica. And he has been conferred the diploma in pain examination of College of Anaesthetists, Ireland, and also the faculty fellow of Faculty of Pain Medicine at Royal College of Anaesthetists, UK. And his special areas of interest are intervention, spine pain, and practices minimally invasive techniques to diagnose and manage pain condition. And I would like to add one sentence more. He is one of my best friends. And welcome, Ajit and Dr. Raghavendra. And I'm handing over the session to Dr. Raghavendra.
Thank you, Dr. Sunil, for that kind introduction. Without further delaying, I will actually start my sharing of my slides. Sunil, are you able to see my slide?
Yes, sir, we can see.
We can see.
So the topic which has been assigned for the next 20-25 minutes is something which I have to do a brief introduction to chronic non-cancer pain, because most of you would have dealt in exclusivity or in depth with cancer pain and how we go about doing cancer pain management. Chronic pain is also, on terms, on a similar platform. It's almost similar in the consensus could be in thought or the mechanistic based way of actually thinking about it, or holistic way is what I would like to put across. I'll have a definition to be mentioned here. What's the prevalence in contrast to the global prevalence? To introduce a few slides about pain introduction and some cases. So what is pain all about? It's just a signal there is a disease or there is a problem going on somewhere, which alerts our conscience to actually to go and get something sorted out to prevent that further damage happening. Now, is it pleasant? Yes, it's more of a term. It's more of an unpleasant sensation is what it's all about. It's the most common symptom why a patient would actually come to a physician. So that's the most important aspect for a physician as well as for a patient, that we should know about this symptom very well. Now, there was a definition which was given in 1979 as an unpleasant sensory and an emotional experience, and other things which were mentioned in 79. There is a revision of this definition in 2020 as an unpleasant sensory and emotional experience associated or resembling that associated with the actual or potential tissue damage. But the definition also was changed because of various aspects which they thought was very important, and they added 6 pointers. I've just summarized those 6 pointers. The first thing which is most important of that is it's a personal experience. So anybody could have a pain which is actually described saying that it is severe and it can't be unbearable, wherein you would perceive that as a normal pain or a normal thing. Pain and nociception. I will just come in the next few slides. That is, nociception is the process of actually you're transmitting your pain, whereas pain is the perception. So these two are not the same. They're going to be different. Why it is different? That's something which I'll come to in the next 3 or 4 slides. Experiences, what you're going to live along your life, or you've heard, you've thought, that counts a lot for actually you're memorizing, you're keeping your memory about pain. That's also important. Accept reporting of pain. That is, we as physicians should accept that whatever the patient comes to us and saying that there is severe pain means we should believe them, not to think saying that we would be judgmental about whatever they would be looking through for the help, and we need to actually support them. First of all, accepting that there is severity of pain is something which is important. Protective, that is, the pain as a symptom, as I did mention just before, is a protective phenomenon. But once it becomes chronic and it's not going to protect anymore, it becomes a lot of issues and concerns affecting the entire the entire system as well as the person, and it becomes more of maladaptive over there. Now, there are issues and concerns wherein the person is going through a lot of concern of pain, but is not able to communicate. Could be because of language issues, because of various other barriers it could be. So therefore, all these things should be considered. And this has been mentioned in the definition in 2020. So it's a persistent pain should be considered as a disease state. It's just not a symptom. So we should take pain as a disease state by itself. And we have to look into what are the causes, just not merely a nervous system injury or nervous system problem or just a symptom. So it has to be considered as a disease state, which all the international bodies have mentioned. And basic human pain relief is something a human right, as all of us in palliative world also would accept that. This was a study which was done by the World Health Organization somewhere in 2003. You can see India is somewhere here, and you can see as the age group is more and women are affected more, almost like 30 to 40% above the age of 50. You can actually check that they will have some kind of chronic pain prevalence. This was a SAGE study which was done in 2013. Now, 50 million is what the US government also mentions for chronic pain. And 1 in 5 adults would have some prevalence of chronic pain going on, which will try to bring them to a doctor or a physician. So healthcare burden, costing, as well as the community burden actually becomes more, because chronic pain needs to be managed at the earliest. Is it different on our Indian scenario? This was a study just done some time ago by our own Indian pain physicians. Now, 8 cities, 5,004 respondents were there, and the prevalence was around 13%. So we are not somewhere far away from the international, whatever the numbers has been mentioned. Our tolerance could be a little bit better compared to the international community, or at places wherein compared to urban as well as the rural areas. The urban areas could be reporting more of pain, the rural areas could be reporting of less of pain. So there is no specific data on that, but that's how we also would actually look into. Now, anybody from the audience can mute and can answer this. Do you feel these men are in pain? Anybody?
Anybody please unmute. Yeah.
This is a very important thing which is done in South India.
Yes, I think their pain is numbed by taking a lot of drinks prior to this particular ceremony, which I think would make them like subconscious, or I'm not conscious. The level of pain would have been, threshold would be very high, but because of what they take.
You're talking about substance abuse before going for this. I would see really no, man. This is a religious thing which they would do. I'm not sure whether
not substance abuse. Some drinks which kind of numb them.
So Dr. Meera says there is no pain for them.
So there is no pain at all for them.
Yeah.
Okay.
Yeah.
Because madam is saying that there is some substance which has been taken, under that influence the person is not feeling pain, correct?
The faith, sir. They have the faith in the God and they don't feel the pain.
Absolutely. So that's something which is entirely different, isn't it?
Yes, yes.
Absolutely. Anybody else have a different opinion saying that they're in pain, but still they're holding back?
There are many responses in the chat also. A sense of uneasiness maybe, or a different psychological state to take that pain or accept the pain, culturally appropriate. These are the responses in the chat.
Great. So adrenaline rush makes the superb. So these are all very important answers, what we can actually think about. And now,
yeah, endorphins. Yes, another.
Can you see this?
Response.
Anybody think she's in pain?
No, sir, she's not in pain. She's enjoying it, in fact.
Wow. So there was no thinking at all. Everybody have mentioned it unanimously, thinking she's enjoying that pain. Why is she enjoying that pain is something which all of us should think about. It's painful, though. If you ask anybody,
Because she wanted to take the tattoo.
Absolutely. So, but that's actually almost, if you have to complete that picture of the tattoo on her hand, could be forearm, it would actually take at least minimum of at least 500 or 1,000 pricks, which is going to go on over there. And the second, third day is going to be much more painful. But this is a lady during the COVID phase. Can you see how much they had to actually just hold her to actually get that injection done for her, the vaccination?
The fear of needles.
But if you ask the same lady to undergo this, do you think the fear will be that much?
No, sir, because tattoo, maybe she loves the tattoo, and the reward what she sees after getting a tattoo, her passion or whatever, that may be more rewarding for her. So she's okay to take that break, and maybe she doesn't want to take
I think the class is already done. All of you have actually accepted saying that nociception, that is pain transmission, and pain perception are not the same. Accepted?
Accepted, sir.
So yeah, if it's accepted, then the job is over, Dr. Sunil. Pain is very subjective. Very good. Pain perception is different for everyone. Absolutely correct. So going into it, so why nociception and pain perception are not the same? As I mentioned in the definition of 2020 itself, first of all, we should actually believe the patient that if the pain is severe, or whatever the grading they would say, or however it's affecting, the pain is affecting, is something which we should believe to understand what they're going through. First of all, the things which I would actually think about is, what is their belief about pain? Vaccination is going to be painful. Vaccination is going to be bad. Vaccination will cause these concerns, that concern. So whatever their beliefs, their concerns, what is attached to it, is something which is very, very important. Now, a lady who's going through labor pain will be actually for 9 months sat down by the mother or the mother-in-law or the other people who would come and visit her and be told, saying that this is going to be there, you'll have to bear with it, and you will have to have, and you will get the best reward possible. So this is what reward, it could be what your intentions are, what is your belief, what is your concern. That's very, very important. What's your psychological issue? Now, a person who's got back pain goes to another 5 doctors, gets 3 or 4 MRIs done, gets all the treatment done, physiotherapy done. Surgeon says nothing. The doctor other says there's nothing. Anxiety builds up. He gets frustrated. He gets angry. Now he could have other issues of depression, saying that I'm not able to sit up, I'm not able to work, I'm not able to do anything. So psychological factors play a real important thing, especially on the neuromodulation, that is the inhibitory pathways which actually are there. Cultural issues. Now, the picture which I mentioned first, it could be a cultural thought. It could be something wherein they would actually look into as a coping strategy. If I do this, I will get cleansed. I will become better. My sins, my other things will go off. So I have to bear this. So mentally you get prepared. So that's what exactly one of the delegates, sir, did mention, saying that this is a coping strategy. Absolutely, yes. So it depends upon your mind state. Now, if a patient comes to you, you're able to understand his language, you're able to believe, and he feels saying that this doctor is listening to me, or this person who's sitting is treating me like a human being, and he's understanding what's happening, then his pain, is understanding towards you or opening up towards you is going to be much, much better. He could actually get much more relief. So therefore, his cultural issues, others. Now, other illnesses. Now, if you have rheumatoid arthritis, if you have any other issues and concerns, and you have diabetes. Now, diabetes, with that, you have peripheral neuropathy. So you have rheumatoid plus peripheral neuropathy, your issues and concerns of you not being able to be mobile, and things are going to be much, much higher. So you're going to get bogged down by immobility. Your affected parts are going to be much, much more. So your mobility is less. Your issues and concerns of stiffness is going to be more. Pain is going to be more. So it could be biological, it could be psychological, or it could be social, wherein your support and system is going to be very, very less. Now, social issues is something which wherein your support, your family, how they are, how much they believe. If every day somebody is complaining of a chronic headache or a migraine and would not be actively there for the entire family, I think after the 10th or 11th day, nobody would actually be thinking in terms it's going to be sinister. We've taken them to a doctor, we've done everything possible. Now, after 3 months, you just think after 6 months, it's going to be neglected over a period of time. And the pain could become more and more worse, lingering more, and the vicious cycle actually becomes more and more. So that's exactly what I mentioned. Pain should always be thought in terms of a biopsychosocial model itself. And it's not much different from the total pain concept, which all of you would have learned for your cancer pain. So therefore, I think it has got a similar connotation, and this is where you should actually be thinking about mechanistically. That means it could be biological issue, is it a psychological issue, or is it something which is related to social? So therefore, you're going to pick up on your assessment, find out what is the cause, then go in for exact management plan. So what I did recapitulate in the previous slide was, if there are social cultural issues for the patient, okay, support system or financial barriers, the past pain experiences have been very bad, then the issues and concerns of chronicity will be going to be much, much more. Or biological, now some genetics, some drugs could be actually completely eliminated faster, or when you give these drugs, they might not affect them at all, or conversion actually is less. So these could lead to a lot of issues. Or some genetically determined people will have less tolerance to pain, and other concerns will be there. So wherein you need to have biological issues and problems related to that. Women would, because of their hormonal changes, things will be predisposed to more pain. So biologically, they will be having more issues and concerns. The most important biological issue which our urban group has actually left into the way is the sleep. Now, sleep is something which nobody gives a lot of importance. They work in night shifts, entire morning, they sleep. So the circadian rhythm is completely collapsed. Your gut flora, your other issues and concerns, what is your microflora in your intestine is as much as important as how your neurobiological way of thinking, how you're handling your circadian rhythm related to your endorphin release. All these things become very, very important for a person to cope up with any form of pain. Now, that person who was hanging from the hook could have the highest release of endorphins at that point of time. He could be in a trance. So which could be the most important way of actually coping through that ritual, what he is actually prayed to or look forward to. Or if a patient or a person is depressed, anxious, coping skills are very bad, okay, he's actually having a lot of somatization, okay, personality disorders, and beliefs and emotional stress are there, then definitely the negative attitude and fears are going to be high. The suffering component becomes very, very high here. Now, the effect would be on overall. So therefore, I think it's important to assess which component is more and take it ahead. There are appropriate tools, appropriate mechanisms and ways of actually assessing it. I think it's beyond the scope of this class. It's just been called for an introduction. So I've actually tried to put it across in a nutshell as much as possible. The single most important question everybody would ask, why is chronic pain undertreated? Most of it, it's mainly because lack of awareness from among the patients, lack of awareness amongst our colleagues itself, saying that these are other concerns and problems could be there. There are certain issues and concerns which I would like to present in the next few slides about some of the patients who would actually come to you would have a similar way of thinking. It could be nerve, it could be muscle, it could be tendon, what it could be. So coming to an appropriate diagnosis and management plan is something which is very, very important. If you miss that, you could have a deviation in your complete management plan and might not get the benefit as you would put across to a patient. Now, until here, I've just finished about 10 minutes or so for my introduction to pain. The next 15 minutes, I'll present about 3 or 4 cases. Then we will actually hand it over to Dr. Ajit, who would actually bring about the global scenario of difference. So I'll try to make the case discussions as interactive as possible. If you're allowed to unmute, please unmute and talk. It makes things much easier for us to actually take it ahead. So here is a lady, 21-year-old. She was actually referred to us after 2 years of pain. She had headache. The headache was unilateral, and she had severe episodes of this unilateral headache. It increased with work, decreases with rest. It spread over the ears and the neck, and she has had concurrent nausea and vomiting. Now, she had photophobia also. By profession, she was a secretary, and she used to use the phone and computer a lot. Can anybody give a diagnosis to this?
Migraines.
Great.
Migraine.
Okay.
Looks like migraine.
Any other thing other than migraine? Tension headache. Wow, that's good. But tension headache comes over here. It's usually on the forehead, bilateral. It's like a tight band over here. It's never unilateral, isn't it?
Could it also be related to posture? Related to posture while holding the phone, maybe? Always tilted to one side?
Absolutely. Definitely, yes. So that's a good one. Posture related. So this is the pain which the patient actually was depicting on the picture when you actually was shown. So when you're having a headache, unilateral, photophobia, and nausea vomiting associated, please don't consider it as migraine. Most of us will think it's migraine, and migraine is a wastebasket diagnosis, and everybody would actually put the diagnosis. Most of the patients who would walk in, first thing they would tell is migraine you've got whenever they complain of headaches.
Cluster headaches also.
Yeah, cluster headache, most of it is behind the eye. So that would be a little bit different from what I presented, could be possible. Atypical kind of pains. Now, this is what we actually have a new phenomenon called as text neck syndrome, wherein if you have a 0-degree tilt, and if you're holding the phone a little bit higher up, then the muscles which have to actually hold up your neck, the weight of the head is going to be around 12 pounds. Now, if you increase it to 60 degrees, that is, you've bent your head looking into your phone, to that, you've increased your workforce by around 60% or 5 times, that is around 60 pounds. Now, what happens is over a continuous period, repetitive strain injury is what we call, or RSI. So ergonomic related is related to degeneration. Younger group of individuals will get affected. Now, people do hold the phones, do hold their laptops and iPads in a different sense. So that's something which is very, very common. Now, if you have small joints which are worn and get degenerated, now that leads to a lot of pain signals which can be of this pattern. Now, if the basal occipital 0-1 C1 joint is involved, you could have this kind of pain distribution. Interspinous C1 C2, then somewhere here. Now C2 C3 joint, you could have at 86% to 100% lower down a little bit over here. This is the pattern you have. Cervicogenic headache is something which I was actually trying to describe. Now, it could be muscle related also, wherein you have actually front bobbed your neck and your back is actually, the muscles that have actually taken a major brunt of undergoing that repetitive strain injury over a period of time. Now, what happens is Janetta's upper cross syndrome is what we call, wherein you have weak cervical flexors, tight pectorals, weak rhomboids and lower trapezius, tight suboccipital, upper trapezius and levator, wherein it lead to a lot of patients with a lot of pain. All of you who are sitting over here, please, the most commonest cancer in India is head and neck cancer. Patient would have had surgery done on one side of your neck. And this patient coming to you, the first thing everybody will think about is migraine or psychological, or put them on to morphine. Please don't do that. First assess them. What is myofascial pain is the most commonest, especially after you've actually had radiation therapy going on, because your fibrosis on one side the laxicity is there. And Janetta's upper cross syndrome is very, very common, wherein they've done a dissection of your nerves of the neck around, especially superficial and deep cervical plexus, leading to a multiple host of issues. Or shoulder neck syndrome is something which is very, very common. So we will have to actually have this kind of a thought, saying that this is something which is a probability, which is much, much more common than any of the other aspects. I'm not telling we should forget to actually think about spread of disease and other things. I'm saying that if you have the evidence saying that there's no spread of disease, and if it is not correlating well with anything, please have this in mind also. Now, simple referred pattern. I'm not telling radicular pattern, referred pattern. Referred means it actually is through a myotome. This is what, if you have an upper trapezius trigger point, this is how you'll have headache on one side. Simple holding the phone for 4 to 6 hours every day for talking. This could lead to a one-sided headache, nausea, vomiting if your sleep is disturbed because of your screen time which you're using. Your stress levels are going to go up because if you're in a business or something like that, will be termed as migraine. The most important thing over here is to rehabilitate that person, get him to do exercises, make him sleep better, do activities, and that is going to sort out his issues and concerns. As I mentioned, head and neck cancers, if you have a sternocleidomastoid mastoid removed on one side, this is the headache pattern you have in a patient who's actually having one side normal sternocleidomastoid and other side you've already removed it. So you have gone into complete spasm, you could have a headache pattern like this. Coming back to the lady, an X-ray was done for that 21-year-old lady. The X-ray looked normal, but I did an injection into the joint. That is a diagnostic procedure which we did into the C1, C2 joint. And then she told saying that, yes, my pain is gone. This was actually a cervicogenic headache, which we had. And very well, I did a joint injection, or we could actually do something which is related to an RF also, could be done for the nerve supplying. Now, if this issues and concerns could be because of the disc also. If a disc pain is there, it could be higher up. C3-4, C4-5 also could lead to a lot of headaches because of the spasm and headache on one side. Might be related to issues of giddiness, vertigo, not able to sleep properly on one side, on moving the neck, even on the pillows could be very, very difficult. Now, cervical epidurals, if you have an MRI done, and if you have an issue and concerning of the disc, and cervical epidurals is something which is possible. Now you can see the nerve roots over here. So we would have to see where the problem is, and we'll have to diagnose. That's exactly why I'm actually putting across. My intention is not to propagate interventions. Please don't get me wrong here. I'm just giving you a perspective. I've told simple myofascial pain means you just have to do exercises, going up to the range of interventions, which is appropriately and mechanistically, which has to be given or offered to a patient. This is another patient who's actually having facial pain. He's a patient who's having trigeminal neuralgia for 5 years. Patient had COPD, right heart failure, was already on carbamazepine, 1.2 grams per day. His pain was controlled for some period of time with the neurologist. He had pain which was exacerbated, more than 15 episodes per day. It triggered on talking, eating, drinking, cold air, tearful. So this is trigeminal neuralgia, straightforward. Now this patient actually had undergone a CIS 3D protocol. There was a vascular loop which was actually found on the MRI. The treatment option which was given directly for this patient was to actually get a microvascular decompression neurosurgically. But because of his comorbidities, the patient as well as the patient's family was not keen to undergo the surgery. He was actually given a medication by the neurosurgeon, pregabalin 150 mg, but not tolerated well. he started having giddiness, he started having issues and concerns. In my practice, I've seen elderly group of patients who have actually gone on to tegretol or carbamazepine will have hyponatremia. Some of them have landed up into the ER because of hyponatremia itself. We have got 3 branches. All of you would be knowing of the ophthalmic division, maxillary and mandibular division. If it is maxillary and mandibular division, if there is a vascular loop, the first thing is to have a microvascular decompression if the neurosurgeon and the family agrees to. Or most of the trigeminal neuralgia, 70% are idiopathic. So therefore, we would actually suggest saying that then you can go an RF ablation for V2, V3. And for V1, we would go for a balloon. Because if you do an RF ablation of the V1 distribution, what happens is there will be corneal dysesthesia, or sensations are going to be less. It's going to be more of anesthesia of the cornea, leading to corneal ulcerations. But this is for V1 patient I have done. You can see the cannula placed over there. Now that's the balloon, which is over here. So I placed the balloon and actually dilated for a 1/22. Now you can see the foramen ovale here, over here clearly shown. Now this is the RF needle which I have placed. Now, this is a patient who has got a V3 division trigeminal neuralgia. So the needle is within the Gesserian ganglion over here, and then RF ablation is done after motor and sensory stimulation. Now you could have patients who have complaining of lower jaw pain or pains on one-sided because of various other myofascial patterns like masseter temporalis. Please do not forget TMJ dysfunction, the joint which is there over here. So patient with trigeminal neuralgia should be taught about TMJ dysfunction, other associated reasons for problems like denture issues and other things should be actually looked into, especially when you have denture issues. Your pterygoids, lateral and medial pterygoids could have a lot of problems over here. Now, patients with atypical facial pain, even patients who have undergone surgery and things for maxillectomy and others could have atypical facial pains, and the parasympathetic supply is something, the sphenopalatine ganglion block is something which is very well referenced now for atypical facial pains, and this is where how you could actually look into it. Now, this is a man who is the third case. I'm actually talking about a vascular pain. So this is also a neurosympathetically mediated pain, but it's vascular in origin. The other two I've given you muscle, joint, ligament. It could be bone, nerve, primarily. This is a vascular pain. 70-year-old, 8-year-old male, hypertensive, diabetes, uncontrolled, 10.8 sugars, IHD, post-CABG, chronic smoker for about 50 years. He was peripheral vascular disease. He was post-angiogram, peripheral angiogram was done. He was post-plasty. The problem was he was able to actually get the circulation up till the ankle. Below that, the toes were started getting gangrene. We could not feel the dorsalis pedis on the biphasic flow. There was no monophasic flow also in these vessels on the vascular Doppler. He started developing ulcer of the foot and it was non-healing. He had severe pain, intractable to multimodal pain medication. Multimodal means, I'm not talking about opioids over here, neuropathic pain medications, vascular surgeon giving me his medications, all the other host of medications, inclusive psychological issues and concerns were actually catered to. Even cessation of smoking, that is something which we wanted to think about, and that was also handled for a period of time, but still the patient did not become better with all this multimodal approach. Now, what would be the next way of actually handling this over here? There's something called as lumbar sympathetic plexus, wherein you have the sympathetic ganglia L2, L3, L4. So we could do a ganglion RF ablation. So this is where the needle is. This is the first needle is at L2 level. Now that's how we've placed, dye injected, checked for RF ablation going on. Now this is at L4. My RF ablation is going on over here. I'm placing the needle at L3 also. So this is how it is. The last case I would be presenting is, she's a 31-year-old lady, Mrs. X. She was a financial consultant and she was independent. She was a type A personality. Pain in the upper and lower back, 12 months, pains and aches. It was more of stiffness. The pain was actually, numerical rating scale would start at around 2 to 3 by 10. And now it has actually progressed to 8 by 10, wherein she was not able to actually withstand this pain or bear this pain at any point of time. It was continuous, widespread everywhere. It used to radiate to left lower limbs as well as the upper limbs, arms. Increased with any form of movement or activity, decreases with rest. She has associated fatigue or more of weakness, and there was numbness is what also she did not currently put across. There was no demonstrable weakness is what I would mention. Anybody would actually take a guess on what the diagnosis could be over here? Widespread pain, issues of overall everywhere, young lady.
Fibromyalgia.
Yeah, so fibromyalgia is something which, this is where how she actually, when I showed the body diagram chart, she marked everywhere. And you could see saying that all those points which you would come in the American College of Rheumatology, whatever the diagnostic criteria, it would actually fit all the 18 plus. Fatigue, not interested in anything. She had stopped working since 11 months. So she was, though she was very, very independent. Mood, she was depressed since the last 2 years. Mainly, she was married. She did not have children. And the children thing had become multiplied because everybody would actually be asking her the same thing. And she was actually getting really affected. She had achieved everything possible. But this is something which she never thought is going to be that difficult. So hence she was disturbed for the last 4 years. The sleep had gone completely haywire because she was married. Since then, she wanted to actually do this, but she couldn't. Isolated from family and friends. She had no suicidal tendencies at that point of time. She had visited a psychiatrist and she was on chlordiazepoxide with clonazepam. Gastroenterologist, multiple times scope done for gastritis. Urologist, because of, she thought it's urinary tract infection. So antibiotics, multiple courses of antibiotics were given. Osteoarthritis was something which was already subjected to a knee X-ray, and the orthopedician had told it could be early stages of osteoarthritis, and there was no signs of it. Neurosurgeon MRI was done. They was actually told not much of a disc, so conservatively they had told. Gynecologist had looked into her issues. There was nothing on USG or any of the other things. Only fatty liver was picked up. Everything was normal, literally over here. Now investigations were done, and I think we got into the lifestyle. I just wanted to mention that how she used to eat coffee 5 to 6, chat. She used to drink every day in the night. So all these things were there, and she used to wake up lately from 10:30 to 11 in the thing because she was dejected. She was not with the family in interacting with them at all. Now I drew a triangle, and this is exactly what she put across. Depression, she gave 200%. Pain was around 85%. Now, I told it's on 100. She told, no, I have to give this 200%. Sleep is something which she actually would take her drink. She would actually take her medications from psychiatry and then go to sleep. But she would never feel refreshed in the morning. So this is something which needs to be handled. So management, you have to educate the patient. Lifestyle changes. Stretches is what is most important for a fibromyalgia patient. Psychological counseling. Something called as CBT is something we actually put across, or ACT therapy. Acceptance and commitment therapy is something which we do it at our place. Psychiatric consult was continued, and we changed to duloxetine and pregabalin on a small dose. Paracetamol was the only drug which we told her to take if she had issues. Now, what I want to mention as a condition as fibromyalgia, one is tender points and trigger points. A trigger point is something which we see in a myofascial pain, muscle pain, which is very, very common. Everybody could have muscle pain. Whereas a tender spot or a tender point is something which you see in fibromyalgia. Now, what is a myofascial pain? Pain in the muscles. It decreases range of movement. It could be related of poor ergonomics and postural related issues. That is what I always mentioned as repetitive strain injury. Whereas fibromyalgia is widespread pain. It could be across both the sides of the body, upper and lower trunk, both involved. Extremities also involved. Trigger points are on the muscles. So you can feel a tight band like of a thing. And when you actually compress or you do a dry needling, you have something which is called as a jump sign when a trigger is getting released. Whereas a tender point is something which is found in fibromyalgia. They will have poor sleep, as I had mentioned in my patient. There's no referred pain pattern, which I've mentioned in most of the muscles which I've shown. It's a tight band. They would actually say stiffness and other things only are localized, whereas this is a generalized phenomenon. And fatigue is something which is much, much more. I can go on. There are other cases, but I think I should stop over here. I'm actually overshot the time. I'm sorry, Dr. Sunil.
Yeah, it's okay, Dr. Raghavendra. I think we will move on to Ajit. Ajit?
I'll stop sharing.
Yeah.
I've stopped sharing.
Sunil, hello, can you hear me?
Yes, Ajit.
Hello, Sunil. And you can see my slide?
Yeah, you are in dark background.
But can you see me?
It's a little bit dark.
Oh, I think this is the most light I can manage here.
Okay. Yeah,
UK
go
is
on.
not a very bright country. Sorry. But you can see the slides and
Yes,
hear
yes,
me
yes.
properly, isn't it?
Yes.
All right. Okay. So good evening, everyone. Thank you, Sunil, for giving me this opportunity. I have been a friend of Sunil since maybe, how much is it, Sunil? 26 years. And he's an excellent friend. He's a great human being, and he's done lots and lots for the palliative care movement in India. He's truly a pioneer. I think you should all feel lucky to be involved in this course. And Dr. Raghavendra has done a fantastic job in his presentation. So he has done a great overview of chronic pain. And by now, I think you all would be more aware of what chronic pain is. I will add to what Dr. Raghavendra has spoken about, and hopefully this should be of some benefit to you. Now, let me start with the quiz. Could anyone tell me what's common between all these four personalities? Anyone?
Anybody can unmute and speak.
So we have Yashwant Sinha, we have sorry?
Popularity. They're popular.
Of course, they are popular. They're all
Left-handers.
popular. Sorry?
Malignancy or post
They had malignancies, yeah.
cancer
Exactly.
survivors.
All are cancer survivors. Yashwant Sinha survived lymphoma. Kiran Kher, I think, multiple myeloma. Martina had CA breast, and of course, everyone knows about Yuvraj. So we will focus our attention on chronic pain management in cancer survivors, because you're all experts in cancer pain. So I won't preach to the experts. We will, because as people who are managing cancer pain, you would be coming across patients who have had cancer in the past, but then comes back because any pain in a patient who had a previous history of cancer will create a lot of anxiety, a lot of distress, because pain is in their mind a big symptom of cancer recurrence. Okay. Now I will cover this topic under these headings. We'll just have a brief introduction to pain in cancer survivors. I will talk in detail, a bit detail about evaluation of pain, because when we are in a chronic pain clinic, when we see patients, we might have 10 minutes or 15 minutes or maybe 30 minutes to see a patient. In that brief time, we have to come to a conclusion of which bucket this patient's pain is. There is no point in having all patients going through the same protocols, and then in the end, because this patient would keep coming back and back, next time we will see another doctor. At that point, that doctor should know what we are dealing with. They may not have that same amount of time, because in UK, a review appointment is very brief. The first appointment, they give you 45 minutes, but the subsequent appointments is only 10 minutes. So in the first appointment itself, you have to put the patient in a single bucket, whether the pain is a neuropathic pain, whether it's a nociceptive pain, whether it's a visceral pain. That makes life easier. So when the patient comes for review, you just need to then review the symptoms, see what's happening, change medication, do intervention, or psychology, physiotherapy, whatever it is. I'll also briefly go through a couple of cases, especially the spinal pain, because spinal pain is a bit complicated compared to other pain. It's a bit difficult to put that patient into one bucket or the other. So we'll briefly discuss about, and then if time permits, because I'm supposed to be speaking about a global perspective, we will briefly touch upon the opioid epidemic, which you might be all reading about and seeing in the media. So the Macmillan Cancer Support Group, which is the biggest charity in cancer pain, they define a cancer pain survivor as somebody who is living with or beyond cancer and who has completed initial cancer treatment and has no apparent evidence of active disease, or someone who is living with progressive disease and may be receiving cancer treatment but is not in terminal phase of illness or has had cancer in the past. So it is obvious that we have to consider cancer survivor as a very different patient compared to somebody who is having cancer. There are multiple causes of pain in cancer survivors. I mean, you can see it can be multiple etiologies. So that's the importance of having a clear plan in the mind. If the patient comes to us, we cannot put the patient into all of these diagnoses. We need to have very narrow diagnosis so that leads our treatment. Now, I'm just briefly going off track. Now, this is a big problem. I know you're all experts in cancer pain. You are big believers in WHO analgesic ladder. I'm not picking on that. It's a very simple algorithm. It saved millions of people from debilitating pain. It has done its work, but it's probably its time has now coming to an end, because we need to go to some other more better and more comprehensive way of managing pain, especially in cancer survivors and even in patients with cancer. The main mistake is that we treat chronic pain as in cancer survivors as if it is acute or end of life pain, because both are very different. Okay, the way we treat chronic pain is different from the way we treat acute or end of life pain, because acute and end of life pain is a narrow spectrum of pain. We don't need to consider the psychosocial aspects much. We just need to find out the cause, give them as much pain relief as possible, make them comfortable. It's not a complicated scenario we are dealing with. A similar mistake is also to treat every pain in a cancer patient as if it is end of life pain. So any patient who comes with you with any pain, but who has cancer, you can't just give them opioids with the hope that, okay, this is the end of it, the patient would be better. Because pain, as Raghavendra has very well mentioned, the pain is a very complex entity. We have to find out why the patient is having the pain, what is causing the pain, and we have to focus our treatment towards that specific reason why the patient is having pain. So as I said, WHO ladder has limitation in chronic pain. The end of life pain is linear and predictable and responds very well to opioids. But chronic pain is neither linear nor predictable, and use of opioids is not helpful and often is very harmful. And that's one of the main reasons which drew the opioid crisis in America. Okay? Now, WHO stepladder pattern is a simple to use algorithm in patients with severe and short-lasting pain, but its use in chronic pain often leads to unrealistic patient expectation, because you start with opioid, the pain goes away, the patient is happy, then they develop tolerance. Every patient, 100% of patients who are on opioids would develop tolerance. Then it exposes them to their side effects, the pain starts to wear off, they come back and they are unhappy, and obviously it all results in a very poor patient and treatment experience. So that's why there is this small effort to move away from the stepladder pattern to what's called a pyramidal model. It's a multi-model treatment of pain from the start. Okay, so we in the traditional model we have to go step by step, slow by slow. But in this model, we can start disease modifying therapy, psychology interventions at any point. Whatever is the best for the patient at a point, it should have to be offered. Okay, it might be a bit of psychology, because somebody comes with pain which is mostly because of fibromyalgia. Most of the time what they need is mostly psychology. For somebody who comes with, say, intense trigeminal neuralgia, whatever psychology you give, the patient is not going to be happy about. You will have to give anti-neuropathic medications or interventions and thereon. Okay, so that's why it has to be a multimodal. Now, emotion and psychosocial factors of chronic pain and supported self-management. It's a big thing because especially in chronic pain, they are major component of chronic pain. So behavioral and coping skills have to be assessed in every patient, and every patient should be supported to self-manage the pain, because we cannot, especially in West, when a patient would have a review appointment after 6 months or a year, we cannot expect the patient to be getting acute treatments all the time. We have to start teaching the patient about self-management from day one, depending on what the pain is. Okay. Now, as I mentioned earlier, emphasis on diagnosis and medical management is a major component of acute pain and cancer pain. But a cancer pain patient with coexisting chronic pain should receive supported self-management as a part of multimodal treatment. Now, as you can see, when a patient is a cancer survivor, this study showed that when they look into the amount of mental, it is a questionnaire-based study, and when the patient is asked whether they are in good physical health or their mental health is good, their chronic pain seems to be less. So the chronic pain is directly related to their psychological well-being and the physical health. 10 to 40% of all people who survive cancer would go on to develop chronic pain of some form. And biopsychosocial aspects of non-cancer pain in cancer survivors is very important. So when you deal with patients who have been ex-cancer survivors, they have, as I said in the beginning, they have a lot of anxiety surrounding cancer recurrence. So each time they have any pain, we have to be very clear about this reassurance that that patient has to be left. Before you leave the patient, you have to reassure them that this is not a symptom of recurrence, because that thing will keep going on in their mind in the background, and that will affect the pain in a very adverse way. So you have to reassure at any given opportunity that this is not a sign of a cancer recurrence. And patients don't like frequent visits to the hospital, especially if they had cancer. So once they are cancer free and then they develop pain again, we have to minimize their visits to the hospital. They don't like visiting hospital. And most of these patients, they want to go back to their normal self as early as possible. So these psychosocial things has to be considered. And that's why holistic treatment of pain is very important. You have to cater to the aspirations and wishes of the patient. And sometimes we have to also assess what we are doing. Sometimes the treatment is bad, more worse than the symptom itself, because the pain might still be there, but the patient might have a lot of fatigue. Then you just stop the opioid or the anti-neuropathic, and patient is better. They are happy to live with pain. Pain is not always, pain should not be treated always, because if the fatigue is worse than the pain, sometimes the medication is the problem. Now let's move on to evaluation of pain. As I said, evaluation of pain is paramount, especially when you're dealing with patients who keep coming back and back. Okay. Now, how do we evaluate pain? Unfortunately, pain is a very subjective sensation, as Dr. Raghavendra said. We don't have a blood test scan or machine. Okay, there is no painometer. You have to believe what the patient says, but we have to get from the patient the detailed history, which would help us to classify this pain into buckets. I will come to those buckets. Okay. Every patient doesn't need to have only nociceptive pain or only neuropathic pain or only visceral pain or only, say, widespread pain or what's called the nociplastic pain. They might have combination of that, each of 2 or 3. Okay, so you have to have a comprehensive assessment. History is the most important one, but along with that, you have to look into their psychological, social aspects, physical examination, and sometimes even imaging like MRI. Okay, so this is a brief overview of how the pain signals are transmitted from the periphery. This is the receptor, then the nerves, then the spinal cord, through the spinothalamic tract, and then to thalamus and to the cortex. This is a brief. This is not exact science. I mean, this has all changed now, but this is roughly how the pain is transmitted. And depending on what the pathology is, the pain is different. So for example, nociceptive pain, which is the most common pain, like say the pain of a fracture, infection, trauma, cancer, even cancer and surgery. It's all because of activation of nociceptor. So that pain has a specific character. Okay, so these characters are clues for our diagnosis. Now, neuropathic pain is pain which arises from nerve damage. Okay, so that pain would have characters of neuropathic pain. Now, the nociplastic pain, which is a pain, a widespread pain of fibromyalgia, irritable bowel syndrome, TMJ dysfunction, all those things, they have a lot of psychosocial overlay to that, because and it is mostly in the brain and spinal cord and all those limbic system and things like so that's a pathological difference between three. Now, this is how we need to approach. This is how I approach, and this is one way of approaching pain. There might be multiple other ways, but this is one way of approaching the pain, which I think would benefit you when you are in a busy clinic. So anybody comes to you, first thing, okay, you rule out red flags. Obviously, 99% of the patients who you come across would not have red flags, and it would have been ruled out by others, because you might be seeing a patient who has been seen by other specialists earlier. So red flags to begin with. If you have red flag, then of course, then you have to divert the patient to that specific specialty. Then from the outset, you have to find out if the patient has central sensitization, because the patient might be referred to you with back pain. But when you talk to the patient would say, okay, I have back pain, I have neck pain, I have shoulder pain, I have IBS, I have this, I have fatigue, I don't sleep. There is no point in treating this patient for any disc or any facet joints or anything. This patient has got fibromyalgia. Their pain is not in the joints, their pain is not in the limbs, their pain is not in the muscles. Their problem is in the central sensitization. The problem is in the central processing nerves, which process the pain signals in the brain. That has to be tackled. That can only be tackled by what's called comprehensive biopsychosocial approach. It might involve some pregabalin or duloxetine, psychology, physiotherapy, lots and lots of reassurance. And in UK, they go for pain management program, which is 6 weeks program, where they are given constant physiotherapy, constant encouragement, as Raghavendra said, mindfulness based, CBT based, lots of other interventions, basically talking therapy, talking. Okay. And then if it is not fibromyalgia, if it is more localized pain, then we have to find out what is then the bucket. Is it a neuropathic pain? Is it a somatic pain? Or is it a visceral pain? And depending on what pain it is, then you have to give either medications or interventions as appropriate. Now let's discuss a couple of cases. Okay. So this is case number 1. Okay. So this is a lady who is a manager, high achiever, sudden severe back pain after lifting 5 kg box at work. Okay, severe stabbing pain, spasm, worsens with minimal movements. There was some radiation of pain to both legs, especially to the thighs. She felt her legs were going weak. Okay, and her past history, she had chronic back pain with episodic flare-ups for ages. But the important history was that she had lymphoma, which the treatment was completed 7 years back. Follow-ups are all complete. She also has migraine, irritable bowel syndrome, TMJ dysfunction, gastroesophageal reflux disease, associated anxiety, depression, laparoscopic surgery for endometriosis. Okay. Now, she has been in and out of hospital. She's a frequent flyer. She keeps coming back to the hospital, keeps having investigations. Okay. Rich lady, lots of insurance, so no issues in visiting hospitals. 2 similar episodes of low back pain in the last year. Last episode was 2 months back. MRI was done. This is what it shows. Okay. And what it basically shows is degenerative changes at L4 and L5. There is a diffuse disc bulge which encroaches on traversing L5 nerve root. Extensive modic 1 changes at L4-5. Now, she has had multiple treatments. In the past, she had similar, when she had similar problems, she had got admitted, traction, absolute bed rest for 3 months, lots and lots of Ayurveda, physiotherapy. Okay. And on examination, she walks with a very antalgic gait. Okay, diffuse tenderness over the whole of the spine. Sensory motor examination is normal. There is no objective sensory or motor deficit. Now, the question is, what should we do next? Can anyone give the answers? You can put in the chat box if you want, so that we don't speak over each other. A, B, C, D, E. Hello? Yeah. Okay, I can see somebody said D.
Yeah.
Reba says D. Anybody else? Okay, Mira says C. Okay, anybody else? A, urgent MRI scan. Christopher says, yeah. Shashikala is going for C.
Yeah, Dr. Domikumari says C. Jaswinder says A. Amina.
Okay. Anybody wants to go for B? X-ray? Easily available? Cheap?
I think Vishal would like to go with B.
Okay. Okay, B. Yeah,
there
we got
are a
B.
lot of response there.
Yeah. Good. Excellent. Well done, guys. So thanks for the response. But what would I do? 1 second, sorry. I would send home with painkillers and advise to stay active. Why? See, all she has is, she is this typical patient who is having nociplastic pain. Let's go back to the history. She has got pain everywhere. Okay, you say it, she has it. Okay, she might have lymphoma, but it's all cleared. She's in and out of hospital every month. I mean, if she had recurrence of cancer, it would have been picked up by now. Now, all the other pain problems she has, migraine, IBS, TMJ, GERD, laparoscopic surgery for everything is what's called contributory to central sensitization pain. And there are some people in the pain circles now who are increasingly coming up with this view that a lot of these problems are actually part of the same fibromyalgia spectrum. IBS is not a disease. TMJ is not a disease. Okay, a GERD is not a disease. It's all part of the central sense. The problem lies in the brain, not in the gut or in the TMJ joint. Okay, so when you see these patients, they all will have these sort of problems. So if you start treating TMJ, if you give them injection, give them surgery, they're not going to become better. If you start giving antacids to GERD, they're not going to get better because there is a lot of what's called autonomic hyperalgesia and all those things going on. The problem lies in the central sensitization. It has to be dealt with. Now, there is a question, why not MRI scan? She had an MRI scan 2 months back. It's normal. She had same presentation. How many MRI scans can you do? Okay, MRI scan is not going to show us anything which, see, the findings which has been shown in the MRI scan, these are all normal findings. These are all age-related changes. We'll come to that. Okay. Now, and her examination is absolutely normal. She has no red flags. Okay. And there is no reason for admission, blood investigation, absolute bed rest, traction. You're only going to make the problem worse by making her not exercising or tackling the problem. And what is a neurosurgeon going to do? There is nothing to take out there. Okay, so there is no role for a neurosurgeon. Okay, now this lady has lots of what's called yellow flags. Now, what are the yellow flags? Yellow flags, like, red flags are things which are sinister, which are life-threatening. Now, yellow flags, there is also yellow flags in chronic pain. I'm sure you'll be aware of that, but I'll just go through that again. These are factors which are psychosocial factors which makes the pain chronic and which makes the patient suffer for a long time. Okay, there will be fear avoidance behavior. The patient would refuse to move. They will think that if they move, the spine will become even worse. Catastrophizing. They believe that there is something serious like cancer which is causing the pain. They believe that there is a fracture in the spine which is causing pain. Okay, and over reliance on passive treatment. It's very common in India. They don't believe that exercise would help. They don't believe that passive. They only believe that passive treatments like massage and medications and injections and oils and rubs and all, Ayurveda, whatnot. That's only treatment. Okay, and there is a huge industry going on with passive treatments. Now, the biggest problem which I find weird is the iatrogenic harm which we do to these patients. So we give this wrong messages starting from the MRI report, which says degeneration. Degeneration is a very pejorative term. If somebody sees a term degeneration in the MRI report, they think that the message they get is that somehow something is crumpling in the spine, something is getting okay, that sort of feeling, that's what they get. A lot of my relatives send their MRI reports to me and say, oh, my MRI says spine is degenerating, what should I do? So now actually there is this thing in US that they're moving away from describing these terms in pejorative terms. These findings, they are actually saying your spine shows age-related changes at L4-5 days. Okay, they don't use these sort of terms like degeneration. Okay, then when we start saying all these things, then they will refuse to move. They will refuse to exercise, because exercise is what makes these patients better. So when you go into this pain cycle where there is an injury, they have pain, then they have fear of further injury, they will avoid moving, then they go into disuse and disability. The muscles, ligament, joints, everything become weak and they become deconditioned, and any deconditioned spine or muscle or joint, even if there is a small movement, that will again cause a sprain, and that makes further injury, then further avoid. It goes into a vicious cycle. Now, if you want to treat it, at some point you have to break the cycle, tackle the fear, they have to confront the pain, start exercising, start moving, and then only they will recover. Now, coming to that question, when to scan? Okay, so do not offer MRI scan for anyone with low back pain or sciatica without the fact that this is going to change the management. If you think that, okay, this patient, even if I have sent for the MRI scan, whatever it shows, the management is going to be the same, then what's the point in? So that's what the NICE guidelines 2016 says. Don't offer MRI scan unless you think that it's going to change the management of the patient. Okay, because the patient had an MRI scan 1 month back, same symptoms coming back again this month, same symptoms. Even if you have the MRI scan and the same symptoms are there, we're not going to change the management. So don't offer MRI scans. For example, this is a typical MRI scan, which this is a typical study which shows that MRI scan is not useful for axial low back pain. Okay, MRI scan serves two purposes. When you do MRI scan of spine, it's for two purposes. Number one, to rule out the red flags: cancer, infection, fracture, inflammation. Okay, over. Okay, less than 1% of all back pain is coming from red flags. Now, what's the second important reason why you have MRI scan? Second important reason is, can anyone tell me what's the second reason why you should have an MRI?
So if you're doing any intervention, if you're planning for an intervention.
No, I won't say that. You don't need to have an MRI scan before an intervention. You don't need to. The second important reason is to find out if the patient has a nerve root impingement, because the patient is having a radicular pain or a sciatica. So if the patient doesn't have sciatica, okay, you don't have any clue from the history that there is no red flags. The patient doesn't have any weight loss, no problem in sleeping, no night sweats, no history of cancer. The patient is in the middle age. He's not a young patient or a very old patient. So these are all red flags. So if the patient doesn't have red flags, then there is no point in having MRI scans. Okay, so so MRI scan is to rule out red flags, and the second thing is to find out if the pain, the radicular pain or the sciatica, is coming from a disc prolapse. This disc prolapse is a common reason why somebody would have. Now, why it is not useful for a simple axial low back pain? So this study, so they have scanned patients and look at, I'll show you, it's a bit of a complicated thing. So these are the imaging findings of all the patients, and depending on the age group, so patients who were under 45, between 45 to 55, 55 to 65, they were grouped according to the age. Now see disc degeneration, imagine. So what I have underlined is a percentage. So if you're less than 45 years, the chance of your disc degeneration shown up in MRI scan is 77%. By the time you are 65 years, it is 100%. So if you have somebody who comes with you with an MRI scan and it says he's 65-year-old and it says there is no disc degeneration, that means only one thing: that person is lying. He is not 65 years. You cannot have a 65-year-old patient without disc degeneration. Okay. Now, okay, disc degeneration is not a pathological thing. You accept that. Okay. What about disc bulge? We are all worried about disc bulge. Disc bulge. Okay, less than 45 years, half the population would have disc bulge. All of these patients, they are all asymptomatic. They don't have any back pain. Okay, they have only scanned people who have absolutely no back pain. Okay, so these are all asymptomatic patients. So disc bulge, half of them would have disc bulge by the age of 45 years. By the age of 65 years, it's 83%. So disc bulge is also age-related change. Now, what about disc protrusion? Disc protrusion is slightly more. Disc bulge is divided into different things like diffuse disc bulge, protrusion, extrusion. Now, if you look at the disc protrusion, even disc protrusion is very common, 35% in patients who don't have back pain. Now, stenosis. What about stenosis? Stenosis is also an age-related change. By the time you're 65 years, even if you don't have back pain, you have 21% chance that you will have So people who are here in this audience, you go and have your MRI scans. I'm sure, depending on your age, all of you would have one of these. I'm sure there is nobody here who is, say, 17 years or something. Below 17 years, you may not expect these changes. But by 45 years, we should expect these changes. Now, the question is then, you have these changes. So I'm going to take an MRI scan now. I have this change, but I won't go and nobody will give you an MRI scan if you're asymptomatic. But I have back pain. I go and have an MRI scan. But how do I know these changes? Suppose I have an back pain today and the leg pain. Then I have different sciatica. They offer me an MRI scan. It shows disc bulge. But how do I know that change is new or is it pre-existing? There have been millions of studies which have been done, especially in the Scandinavia. All of them, they have shown that what they have done is that they have taken asymptomatic people and they have done a baseline scan and they have followed them up over years. And each time they develop a back pain and leg pain, they make them undergo an MRI scan. And 96% of the repeat MRI scans were normal when they present to the casualty with back and leg pain. 96% of the MRI scans were normal, or the positive findings were pre-existing. So all of them had a baseline scan. Okay. So these are all age-related changes. So when we age, it is not just our skin which changes. We develop wrinkles, we lose hair, we have gray hair. The inside of our body also ages. So these are all aging of spine, loss of T2 signal, basically loss of water in the disc, narrowing of the disc. Disc bulge is also age-related. Facet joint arthrosis is also age-related. So the summary is that don't treat MRI. So these structural changes are very common. It has to be the patient's pain has to be concordant with the image finding. Otherwise, MRI is not of any use. Okay. Then the question is, okay, why don't I just scan because it is reassuring for me and the patient? No, it doesn't. It doesn't improve reassurance because the problem is that it shows all these problems in the MRI scan, and it actually makes the patient more anxious and more distressed. Let's go to the second case. Now it's a 55-year-old man, fit and well, low back pain, leg pain for 4 weeks. Started after a day of gardening, sharp stabbing pain which extends from the gluteal area and spreads along the back of the thigh and calf to the foot. Pain is worse on walking and turning in the bed. Associated numbness in the left leg. Okay, no weakness, no bowel or bladder symptoms. He has past history of smoking, had renal cell carcinoma 10 years back, and it has been treated, completed treatment, follow-up is fine. Now he was unable to weight bear, was admitted under the orthopedics. They examined, he had a slight reduction in sensation L in S1 dermatome. There was grade 4 power, SLR was positive, Prost SLR is basically SLR on the other side, that's also positive. This is what his MRI scan shows. So the lowest disc, you can see the lowest disc is black. So that is that is what is degenerated, and it's gone down. It's basically protruded, and you can see here that is gone and it is pressing on a nerve root. This is the nerve root of the opposite side. This is the nerve root of the left side. Okay. So what it shows is left-sided disc extrusion towards the lateral recess is compressing left L5 and S1, but caudate vena is not compressed. Now, patient was advised surgery. The patient was not keen on the surgery. So put on medications, traction, and physiotherapy. And how did he progress? He discharged home. He wanted to go home. He was discharged, and he was obviously advised to report to casualty if the pain worsens or if he develops caudate vena. He was put on lots of medications: tramadol, pregabalin, thiocortisone, nortriptyl, diclofenac. The pain became bearable, but it was causing severe sedation. He was sleeping most of the day, not able to go back to work. Then they took him to Ayurveda. Obviously, they stopped medications. Pain recurred, similar pain, again unable to mobilize, but no bowel or bladder problems. Okay, what would we do next for this patient? Let's have some answers, please. Okay, okay, few of them are saying epidural, physiotherapy, good answers, good answers. Yeah, come on, let's get the answers coming. Yeah, that's good, good. Excellent, excellent answers. Thanks everyone, that's good. Okay, okay, let's go to what I would do. Okay, I have to agree with Raghavendra. What are we going to do? We are going to do an epidural. That's what he got. He got an epidural. So this is, Sunil forgot to mention, actually, I was in India for the last 3 years. I came back now. So this was when I was working in Cochin, actually. So this is, I can't put images from UK because of some data protection issues, okay? Because I have to go through the data protection office and get their permission. It takes ages. So this is what he had. He had an right L5 transforaminal epidural steroid injection. Sorry, these images are from different patients, but obviously matches the symptoms. Okay, so this is what the epidural spread is. Now, what happened? He reports complete pain relief post injection, and on follow-up, 80% pain relief ongoing. He has occasional follow-up, which he is managing with simple analgesics. So in this situation, this patient would come in this bucket, the neuropathic pain bucket. Okay, we have ruled out red flags. He didn't have any symptoms of central sensitization of fibromyalgia like the first patient. Then we had to find out which type of pain it is. It was a neuropathic pain. It was a sciatica. It was going down the leg. There was sensory symptoms. So we put it in this bucket. So this is an algorithm for low back pain. I don't think you need to. So now, when you're dealing with somebody who has low back pain and leg pain, a very important thing after you rule out red flags and yellow flags, that is fibromyalgia, is to find out whether this pain is radicular or referred. Radicular is neuropathic and referred is somatic. This is very important because the patient's treatment is very different if he has a neuropathic pain, and it is very different if it is a somatic pain. Now, not all back pain with leg pain is radicular or sciatica. So if somebody comes with back pain and leg pain, you can't just say it is a sciatica, because in fact, most of the time it is a referred pain. It is what's called an axial back pain, and the pain which he's having in the leg is referred pain. Like you have heart attack, you get pain in the left arm. You have cholecystitis, you get pain in the right shoulder. In the same way, when you have pain coming from the joints in the back, like say facet joints or sacroiliac joints or the intervertebral disc, it can radiate into the leg. So that is a referred pain. Okay, so this should not be mistaken with radicular pain. Okay, this is the most important factor, as I said, once you rule out red flags and yellow flags. And the information about whether it's a referred pain, radicular pain, comes only from history and examination. MRI scans don't count at all. Okay. Now, how do you differentiate? These are the different points. As I said, referred pain, it comes from joints and disc. Radicular pain, it is a problem with the nerve root. I showed you the first that picture earlier. Neuropathic pain is coming from the nerve damage. So in a disc prolapse, the pain the patient is having is because of stimulation of this dorsal root ganglia by chemicals which are released from inside the disc. So the intervertebral disc, the nucleus pulposus, they have a lot of chemicals like phospholipase A2. Where do you find phospholipase A2 apart from the intervertebral disc? They are found in snake venom. Okay, so it's so irritant. So that's why when you have intervertebral disc, you get this intense, sharp shooting pain. Okay. Now, in referred pain, the pain would be predominantly back pain. So back pain would be more than leg pain. But in the radicular pain, both would be the same, or even leg pain would be worse than the other. And referred pain usually doesn't go below the knees. Okay, it goes up to the knees. It's in the thighs or the hips. Now, radicular pain, depending on which nerve root is involved, it can go down L4, L5, S1. All of them goes below the knee. Okay, the character of the pain is different. Referred pain will be dull, lacking continuous pain, but radicular pain will be more sharp, electric shooting type of pain. And because it is involvement of nerve root, you might find, if you examine, there might be slightly reduced sensations, or the reflexes like ankle jerk or knee jerk might be reduced. Now, as I said, inflammatory mediators are the reason for radicular pain. Okay, most of them it is L5 and S1. You have to find, to be exact, radicular pain is different from radiculopathy. Radiculopathy is when you get nerve damage. So in that patient, we had radiculopathy because the power was grade 4. Okay. Now, this is a neurophysiology behind referred pain, because see, the spinothalamic tract is a very, very narrow tract, but the peripheral nerves are maybe 10, 50 times more. So not every nerve can reach the brain. So when you reach the spinal cord, a lot of these nerves has to connect to the final nerve. So when there is connections, the connections from two different places will go into one nerve, and that's the reason why you get this referred pain. Okay. Now let's go back to that patient. And so I'm talking about epidural. You must be thinking, why epidural? What is the reason why? Now, these are the indications for epidural. Epidural is given for severe radicular pain in a prolapsed intervertebral disc early in the course of disease control. There is no point in waiting for 6 months, 7 months to see whether it improves. Okay, because can I ask you, if you have a fracture in your wrist, would you wait for 6 months? Or if you have a fracture in your femur, would you wait for 6 months to see if the fracture heals by itself? If it doesn't heal, then I will go for a operation. No, it doesn't work like that. In the same way, if you have a disc prolapse, you can't wait for 6 months thinking that there is a pathology that it has to be dealt. It has to be either an epidural or a discectomy. So that NICE guidelines 2016 is very clear. If you have radicular pain, it is because of a disc problem. It has to be tackled as early as possible. There is no arbitrary period of 6 months or 1 year. You tackle it as early as possible. Now, some patients might need surgery, but then they want to avoid surgery. The patient or clinician, the patient might have a lot of comorbidities. They don't want to do surgery. Okay, a patient who is unfit for surgery, and patient has poorly defined surgical target, because the patient has a 70-year-old patient who develops radicular pain. The MRI shows discs at L1, L2, L2, 3, L3, 4, L4, 5, L5, S1. Where will the surgeon treat? Okay, the nerve conduction studies are not very accurate. They have very poor predictive value. So if you do an epidural, I'd say L4, 5, and the pain is much better, then if the pain comes back early, then the surgeon knows, okay, this is the nerve root to be taken out. So this epidural steroid also helps in diagnostic clue to the source of the pain. And a lot of these patients may not like the anti-neuropathic medication, because that's the first choice. I mean, the patient comes with radicular pain, you put them on anti-neuropathic. Most of them, they don't need any further treatment, but a lot of them cannot tolerate the sedative side effects. They cannot drive sometimes. So they would like to come off medications. So okay, now what is epidural steroid injection? It's basically a targeted delivery of anti-inflammatory medication, that is basically steroid, into the spine, very near the disc. So we have to put it in front of the spine. Okay, here, okay, in the traditional, in the routine spinal anesthesia or epidural, which we do for say surgery, the medication is done is deposited posteriorly. So that's the difference between the epidural for pain management and epidural for anesthesia. Epidural for anesthesia, it goes into the posterior epidural space. Only very little reaches anteriorly. The epidural for chronic pain, it goes into the anterior epidural space through the foramen. So that's why it's called transforaminal epidural. Okay. Now, we have to be mindful of the fact that not every disc prolapse is permanent, because if you have a patient with disc prolapse, you scan them after 1 year, we often find that the disc prolapse is gone. So the natural history of disc prolapse is resolution. Okay, so you don't need to take that disc out. Let the disc be there. You just need to wait for the body to send macrophages and take the disc out. So until that happens, you can always depend on either antineuropathics or epidural to give them symptomatic. And systematic reviews have shown that 70% of the patients get at least 50% pain, and it avoids side effects of medication. These surgical, a lot of studies have shown if the patients, when in West, they have to wait for 1 year, 2 years to get a discectomy. Unlike in India, where you have disc prolapse, they can take out the disc in the same day. That doesn't happen in the West. You have to wait for 1 year. So what they do, the patients who are waiting for surgery, they give them epidural, and when they go back and look at the data, 80% of them, they don't need surgery. Okay, and avoid central, because as we discussed earlier, if you have a painful problem which persists, it can cause central sensitization. It can make the pain worse. Okay, it can cause then widespread pain and fibromyalgia and whatnot. Now, having spoken so much about spine injections, the obvious question is, are they safe? Now, this is a very recent study from Mayo Clinic. 26,000 patients, okay, not one single complication. The commonest one they had was vasovagal reaction, which is very temporary. Okay, so when you follow guidelines, when you follow safety precautions, these injections are extremely safe. Okay, but the crucial thing is evidence-based guidelines have to be observed. We cannot just do any expect every Tom, Dick, and Harry to do this procedure and expect similar results. This happened. This study is from Mayo, and they have good clinical governance things in place. So that explains this great results. Obviously, there is concern about side effect of steroids, but then you have to be mindful that when we are doing transforaminal epidural steroid, we use a very small amount of steroid. So even the European League Against Rheumatism, they say risk is low when the oral prednisolone dose is less than 5 milligram daily. So when we are using, say, 40 or 50 milligram typically an injection, that is basically equivalent to, say, 8 or 10 days of oral steroid. Okay. Now you might get some immediate steroid flare. Steroid flare is basically you have a spine injection, and the next 1 week or so, the patient might feel like they have a flu, or they might say they have corona, but the COVID test is negative. It is just basically steroid flare, very temporary. The blood sugars might rise for 72 hours. And the cortisone is suppressed for up to 19 days. Okay. Now, but the risk of osteoporotic fracture is only when you have more than 200 milligram. That is equal to, say, 14 injections, which I don't think anybody will get anyway. In fact, there have been studies which shows that steroid injection reduces the osteoporotic spine fracture risk. The reason is very simple. The most common reason for an osteoporotic fracture is immobility. So when you have an elderly patient who is having a lot of back pain because of a disc prolapse, they are basically immobile. You give an injection, they start mobilizing, and the chance of osteoporosis becomes less. Now, I'm sure one of you would then come out and ask, what about paraplegia? What about paraplegia? I have heard that epidural steroid causes paraplegia. Okay, I have presented this and I've been asked this. I've been put into a corner. Epidural steroid causes paraplegia. What do you want to say about that? Of course, it causes paraplegia, but when you look at the numbers, millions of spine epidurals are performed every day, and what has been reported is case reports. In total, there you can count in the fingers how many cases of paraplegia has happened. It is a real problem, but it is extremely, extremely, extremely rare. Much less than the incidence of paraplegia from laminectomy. Okay, the incidence of paraplegia from laminectomy should be at least 2 or 10 times more than this, even more, maybe 100 times. I'm not sure. Now, we are not sit idle thinking that there is a problem with this epidural. We have gone behind it. The Spine Intervention Society has gone behind it. We have done studies, we have done animal studies. We have then found out what was the reason behind it, and then we have stopped it. Okay, so whoever follows the Spine Intervention Society guidelines, they have never had a paraplegia since. What we have found out was that, see, the traditional teaching for epidural steroid injection is that you need to put the steroid in the safe triangle, which is basically the upper part of the triangle. Okay, this is what we have been using. So this is called the safe triangle because it is safe. It doesn't, when you put a needle there, it won't injure the nerve root. So it's been done for ages. Okay, now what happened was that after this case reports, then we started going back, and what we found is that safe triangle is not safe at all, because there is nerve root there, but there is also another problem. There is the anterior spinal artery, the branches of anterior spinal artery. One of the biggest one everyone knows is artery of Adam-Kivitz. That lies in that anterior epidural space, which is a safe triangle. Okay. In fact, if you look into this is a foramen. This is the depiction of foramen. They have studied a cadaver study, and they found that 96% of all the arteries, they lie in the anterior superior quadrant. That's where we have been putting needle in. Okay, 96%. But if you look at the inferior quadrant, there is hardly any there. There's zero in the inferior quadrant, inferior posterior quadrant. There is zero. So that's why now Spine Intervention Society is saying two things. One is go for what this is called the Camping's triangle. Okay, go for that triangle. Or if you have to go here, use not particulate steroid like dexamethasone, because all the patients who had this paraplegia, the problem was because the particulate steroid went into these arteries and it caused coagulation, because they are end arteries, and that's what caused. So if you're using non-particulate steroid, this problem is not there. Now, Sunil, do you have time? Just 2 minutes to talk about opioid epidemic.
Ajit, I think let's take a few questions, and if the participants are interested, we can.
Okay, that's fine.
Yeah. Sridevi?
Yeah, there are already a few questions in the chat. With epidural steroid, when do we expect onset of analgesia, and for how long does it last? Anyone of you can.
Ajit,
so
can
it's a
you
very good
unshare
question.
the screen?
Sorry?
Please unshare the screen.
Yeah, so it's a very good question. Now, it doesn't start immediately because steroid takes time. It might start within a week usually. Okay, so with the epidural steroid, the patient might come in, they have the injection. We put a bit of local anesthetic, so they'll have few hours of pain relief. Okay, and then the pain would come back. So we have to warn them, okay, the pain is not going to be relieved until maybe a week, because steroid takes a week before it calms down the inflammation. And then how long does it last? As I said in that systematic review, 70% of them get 50% pain relief, and the duration of effect is very variable. But on an average, we can say 6 months. But you have to be mindful of the fact that most of the time, 80% of these disc prolapses, they settle on its own without giving any treatment. There is regression to mean. Okay. So we often find we give the epidural steroid and they never come back. Even if they come back, they might be coming back for another pain, neck pain, or then we ask about what happened to the other pain. That other pain is gone. Okay, it might be because of the epidural, or it might be the regression to mean. Okay.
Can I talk about my experience?
Yes, Dr.
And I think it's in consensus with Dr. Ajit. The only thing which I would actually stress upon here, the longevity, how much they could get in our country is, we should stress upon what is the exercise they should be doing. They don't actually see for them, most of them, for them, physiotherapy is ultrasound or IFT. And all our physiotherapists are looking at only about IFT or ultrasound. And I, in chronic pain management, would never ever use IFT or ultrasound as a therapy modality. I would actually tell them, take a 6-day course. Most of my physiotherapists would be trained in manual therapy, wherein they would actually assess which muscle is actually hypertoned or which is lax. Then first 2 days of actually getting the right kind of exercises to be taught by the physiotherapist. Next 2 days, 50% by the physiotherapist, 50% would be followed by the patient. The last 2 days, 100% would be done by the patient, and the physiotherapist would guide. So that, I think that would take a long way in actually making that pain a little bit better, and that could go in terms of the betterment also.
Thank you, both of you. Another question I'll quickly take. Role of interventional pain in progressive cancers, especially in head and neck and pelvic malignancies. How effective and how long lasting, and what are the choice of intervention?
I think that question is too open. It depends upon, is there a role? Definitely yes. And I would go in for about 5 to 10% of patients wherein it's intractable. In progressive cancers, depends upon where the infiltration is. It into the nerve? Is it, where is it? Is very, very important. What type of pain? As Dr. Ajit had mentioned, is it like somatic, like simple infiltration into the lateral aspect? The psoas muscle is getting infiltrated. Psoas myofascial pain is a different. They will have thigh pain, which is not actually going down. It's not radicular. If it's radicular, where is it? Now, neuropathic pains would not be comfortable with just saying, now, if it's too much into the cord and other places, then would you like to go in for an alcohol ablation? So it depends upon what is the status of the patient and what is the individualized plan which you would have. I think that is where I would stop. I think Ajit could actually throw some more light.
Yeah, I mean, interventional pain in cancer is sometimes life-changing, because so it depends on where the cancer is, obviously. Okay, so if say suppose the cancer is more pelvic or sacral, then we go for what's called intrathecal neurolysis. Okay, so basically you put an phenol. Okay, it basically burns the nerves. Okay, and the patient's nerves to the bladder and rectum would be also burned. But then anyway, by that stage, they would be double incontinent. Okay, but that simple procedure might give them a fantastic pain relief until for say 3 to 6 months. Okay? The same thing can be done for say cancer which infiltrates the chest wall. So here we put the patient on the side and put a spinal, and we put alcohol, and alcohol goes up and it burns all the nerves to the chest wall. Okay, so there are a lot of these interventions. So it depends on what the pain is, and because there is this new thing called intrathecal pump, where I'm sure a lot of you would be aware, we put a epidural catheter, a catheter into the spinal fluid, and that's connected to a pump, and that delivers morphine at a very small rate continuously, and that needs to be changed every 3 months. So that has changed dramatically the pain management of especially these abdominal pelvic pain patients.
Thank you both. Just we have a few more questions, but I would like to ideally we should have a case presentation from the participant side, but we already overshot time, and there are a few more important questions to take up. So I would like to ask the participant, is it okay to go ahead with some of the questions, and especially Dr. Jaswinder, who have come up with case presentation. We'll definitely get back to you with the response from both the experts. We'll send the case presentation to them and get their feedback to you personally, and will be circulated among the participants.
Thank you. It's not at all a problem. Thank you very much.
Thank you, Dr. Jaswinder. I think the next question is very similar to the previous one, role of intervention in pancreatic pain and in spinal cord related injuries. And the same thing, like how helpful it is when compared to analgesics and how long it will last. I think this in line with the last question, but if you would like to add on something, please.
I think CA pancreas, the very well evidenced intervention is definitely there. All of you would have heard of celiac plexus block, but I don't do celiac plexus block at all. I've actually moved on from celiac to splanchnic nerve RF ablation with alcohol, or it could be RF itself, because splanchnic is something which is much better if you have ascites, you have issues, concerns. If the tumor is also infiltrating into the nervous system, it's much better to be done. I've seen celiac plexus. I used to do almost 30, 40 in a year, but once I did celiac, what happens is when you dump alcohol, it's going to go into fibrosis, and the vascularity going into the various the GI system. Postprandial pain used to start off, and in CA pancreas, whereas indigestion is something which is very, very common, you will have more of these issues. So I would say splanchnic would be much, much better. The role is because the patient is actually coming to you very, very early in the disease, as some of them over here. I'm not telling relatively early. I'm not telling CA pancreas is diagnosed, definitely there'll be tumor, and you know that you can just prolong. It's not going to be completely cured to a large extent of them. So early doing could actually decrease their consumption of the step 3 medications. They're, you're talking about survival. Referring to palliation, it's not going to just improve quality of life and dignity of life, survival itself. So if you're able to take therapy, you're able to take treatment, if you're able to cope better, if pain is better, sleep is better, oral intake is better, constipation is better, your survival also becomes better. So therefore, early is something which we can actually definitely sort out their pain if it is definitely severe, referred, or radicular rather than referred, because myofascial pains, muscle spasms are something which is very, very common. And if it's too much after your step 2 medications also, and it's very bad, definitely yes. And he's got issues and concerns of opioids going in and things which is related to opioids, could be constipation worsening with CA pancreas, or sleep issues where patient becomes very drowsy. These are certain things which you could actually also consider. But if you have a person who could be doing interventions at an early stage, when pain is actually the most commonest cause why the patient is coming with pancreatic cancer, then definitely you can suggest at the start itself.
Thank you, Dr. Raghavendra. 2 more questions before we wind up. When would you suggest physiotherapy for acute disc pain and role of TENS in management of chronic pain? I'm asking it together so that you can touch upon what the questions.
So, in my opinion, when you have somebody with acute pain, you have to get the pain in control. You cannot, if somebody is coming with acute pain, 10 out of 10, you tell them, okay, go and exercise. They look back and tell you, are you joking? Okay, yeah, I'm in pain. You are asking me to exercise. It's not possible. So obviously, physiotherapy has a role. Okay, the role is to get the patient back to its normal functioning as early as possible. And as Raghavendra clearly said, physiotherapy is not an active process. It's not somebody giving you ultrasound or IFT. The role of the physiotherapy should be to make sure that this patient is going to be deconditioned if they are left alone. Okay, they should be taught exercises, they should be encouraged, they should be given all the information on why they should exercise, what exercise, why it is not dangerous to exercise. So physiotherapist has a lot of actually what you call the role of a psychologist also. Okay, so what was the second question? Sorry.
The
role of TENS
in
TENS. I don't think there is a much role for TENS in because the problem lies in the disc. Whatever you do in the TENS, it's not going to touch the disc. Disc lies 10 centimeter deep. How much ever current you put in your skin, it's not going to reach the disc. You can do whatever TENS you want. It is just a placebo effect. They say it's all what do you call Melsack and gate control theory and whatnot. but that's not treating the cause. I mean, you're just basically wasting time. Instead, you focus on the problem, give antineuropathics, see whether the patient is improving, then add another antineuropathic, maybe a bit of tramadol, okay, and lots of encouragement exercise. And if nothing improves, then maybe go for an epidural, or if there is a the patient is a risk of developing radiculopathy, the power is becoming grade 4 or something, then go for discectomy.
To answer that in the Indian context, I would have seen a patient who would have already gone to neurosurgeons. One MRI is already done, second MRI is already ready. He'll come to a pain physician saying that I want this to be sorted out by today night. If not, then I don't think so you're a good doctor. That kind of a perception also I've seen in patients. And when I'm actually sitting in a corporate hospital, highly demanding patients also could be there. Now, as Dr. Ajit did mention, saying that you need to actually settle that pain at the earliest. If you want, you could actually directly go in for an epidural. If there is evidence, as Dr. Ajit mentioned, there is a clear-cut pathology which is there. You could identify where the problem is, and it is actually from clinical history, examination, and your MRI diagnosis are all correlating, and then go in for an intervention. And epidural is something which you could do. That's the acute disc pain. And the previous thoughts of acute pain for a disc was most of it was mechanical. Now it's not mechanical anywhere. It is more of chemical neuritis is what we would actually think about. So therefore, when you're actually targeting where the chemical neuritis is happening, that's exactly why Dr. Ajit mentioned the medicine has to be very close to your nerve root rather than in the interlaminar, which is actually posterior packets, is where we were actually usually be thinking of.
You know, they have done this when in 1950s and 60s, when there was no, you don't need to have ethical body approval to do studies and all. What they have been doing, and at that time there was no anesthesia, so patients were having this surgery. They'll be lying on their back. It will be done under local anesthetic. The surgeon will cut open the spine, okay, and what they will do is that they want to know which level is involved, because there is no MRI scan. You cannot see which level is involved. So what they do is that they pinch every nerve and see which nerve is painful, and that's how they take that disc out. Okay, so what I'm coming to is that if the patient has 3 discs, but only 1 disc is painful, they will only take that disc, because in that patient, in that scenario, only that disc has the inflammatory mediators, and that inflammatory mediators has made that nerve very sensitive. Okay, and they have done other studies wherein what they've done is that they've taken disc material from patients who had disc prolapse and it's been taken out, and they purify it and go next door and inject it to the disc of a patient who's having this, nerve root of a patient who's having this surgery, and they cry out in pain. So what it means is that the chemicals from the disc that is causing this intense neuritic pain. Okay, so the disc prolapse pain is actually coming from the chemical irritation of the nerve root. So that's why the epidural steroid works. Okay, so even if you have, if you work in spine, you'll see a lot of these patients who don't have any pain, but they have grade 3, grade 2 weakness, because chronic compression can cause demyelination and weakness without any pain. Okay.
Thank you, both of you. Dr. Sunil, would you like to say a few words and wind up?
Yeah, I think both faculties gave us the importance of evaluating the pain and proper understanding the proper history. And there were, whenever we hear about that pain, and that's equivalent to conduct an MRI. So Ajit says it should not be done, and he also came up with evidences why it should not be done. So I think that was one of the important point. And Dr. Raghavendra mentioned about fibromyalgia and myofascial trigger points. So those all are things which we need to keep in our mind, because we see a lot of cancer patients and we think it is mainly due to cancer. It may not be. So it might be something unrelated to cancer. So there are various causes which can cause chronic pain in cancer patients. Even the posture is a problem which many of us will have. So it is very important to understand the basic of the problem or the cause of pain and treat it properly. So thank you, Dr. Raghavendra, for coming and giving an excellent session, and also to for bringing another perspective to the back pain. So both of you did a wonderful job. Um, so it would be really beneficial for the palliative care physicians. Thank you both.
Thank you, Dr.